Good afternoon, and welcome to the community hour of this incredible event. Before I begin with any introductions, I want to express my deepest gratitude to everyone here for all your hard work and efforts to support us, the frontline healthcare providers, in keeping our patients healthy and safe. And special thanks to fantastic DevDays community for lowering the barrier for me, and so I could attend my first FIRE course in 2022. Who am I? I'm Irina Angel, and you can see on the slide what I do. However, what really defines me in just one word or phrase is, and what I believe is the most relevant to why I'm here, is I am just an ordinary doctor who treats patients. And like many other physicians, I struggle to answer one particular question. Why are these cutting-edge technologies taking so long to arrive to clinics like ours, where they need the most? This is a community hour, and I will be talking about my experience of engaging with various communities in conversations about innovation and fostering the shift in mindset from what's the matter with you to what matters to you. Over past 10 years, I approached executives and vendors at clinics where I worked with proposals to innovate to address the unmet needs of my patients. And the response was always the same. No, it's outside of our budget, or it's not required. And if you are like me, I kept trying. Most recently, in my role as the medical director and the co-lead of electronic health records implementation team, who deeply cares about bringing health outcome research to the point of care, it made sense to me to go to my chief and start the conversation about clinical decision support systems and how leveraging innovative technologies can support our new behavioral health program in achieving our quality care goals. So we talked about how recognizably delayed detection and inaccurate diagnosis pose significant issues in mental health. In fact, guess what? Less than half of patients who come and see psychiatrists see improvement. It's shocking. The community, and it's sort of the commonly used patient's label as a treatment resistant, does not fully capture who's genuinely resistant to treatment and why. So we needed data, not opinions. And my chief said, sure, go ahead, just write something up. And so I wrote the proposal and submitted the proposal to RIB, and fast forward, the project was approved. However, only as a community project for me to work on evenings and weekends, unreimbursed. Nevertheless, to me, it felt like a win. And this is why. This slide shows significant suffering and long-term social and economic costs due to mental health problems, and explains why recently mental health moved up the list of national and global priorities according to World Health Organization and clinical decisions and CDC. The statement the Lancet Commission that when it comes to mental health, all countries can be thought of as a developing countries holds true. And what this slide, and I have all the references if you need anything, any statistics in a long list, what this slide does not show that those unfortunate individuals were in treatment, in psychiatric care, when all the things went wrong. And however, I don't want to be negative, and there will be a happy moment down the road in my presentation, but I want to point it out to this buried last line there where it says that every dollar spent on mental health effort equals $5 in savings, and that's why I felt good about my decision to do everything I can to move my project forward and to, contribute sort of gaining control over the mental health crisis so our world does not turn into the grave. And so this is a diagram. It's one of my favorite diagrams. In fact, it's like my life. I spent like 30 years here. This is so classical mental health treatment cycle, starting with our number one, and that's kind of like a way where the patient meets the clinician and progressing through their stages from 2 to 5. And those little stars, the green stars, and they represent the areas where the data gap in care is, and informatic solutions can enhance the outcome. So let's say we're at point 3, and where the provider evaluates the patient's progress and updates the treatment plan. And we want to change it. So let's say we want to integrate the patient's reported outcomes, like PROs at this point. And at the time of the design of the treatment plan, at the time of the update treatment plan. And what I did, I just started with like our electronic health records, and I created a synthetic patient, synthetic record for a fictitious patient, and who, say, have treatment-resistant issues. And I admitted this patient in April. And then I'm scheduled to discharge the patient right after my presentation. So I have this patient's credentials. I'm a patient to access the portal, and I'm a provider, so I can test my prototype. So I started prototyping, that so-called CDS hook, and I gave a name called my treatment CDS hook. So let's take a look. So this is a little sketch, and so just before kind of breaking it down, the provider every 5th day of treatment evaluates the patient's progress and uses the clinician's global assessment scale, CGI, like one questionnaire. Before updating the treatment plan, so I'm a provider, I'm a physician, I'm placing the order for the task, for this patient, to complete the so-called credibility expectancy questionnaire, CQ, to measure and quantify the patient's expectations and perceptions about the improvements they believe I achieved because of the treatment and how believable, convincing, and logical the treatment seems. So this audit task would be comparable to, say, a primary care provider sends the patients to the laboratory to kind of check their, say, cholesterol after completing the, say, course of lipid-lowering agents and to obtain data on the effectiveness of the treatment. So I'm not going over all the additional details of the design because of the time limits, but what's valid here, and just like a very valid reason I would just say that the step of completing the CQA, so credibility expectancy questionnaire, must be in portal. So, and this is why this 1, 2, 3 steps, we were starting with portal. Portal, patient fills up the CEQ, and which triggers that my treatment CDS hook, and then kind of a remote CDS service gets involved and escalates to its own rules, and then leveraging FHIR data, prefetch FHIR data is needed, and then the service renders this card to their patient, and the content of the CDS card can be linked to the patient's current treatment plan, and its purpose, of course, multiple functions, for example, to build the patient's coping and provide personalized education on kind of problem-solving strategies, etc. But we want to close the loop, so I'm sketching here that pretty well-established patient CDS hook, which exists, and we can reuse this template that already been built by champions, and thank you. This is very straightforward. Provider opens the patient chart. I'm a provider, triggers the patient's CDS hook, and invokes CDS service, and CDS service escalates its own rules, and leveraging the FHIR is needed, and then CDS service displays that renders a card containing the provider's recent order results, this questionnaire, and including the score, and that the provider can compare this score with his score or her score or their score and their treatment recommendations if there is a discrepancy. things like that. So there's like a little bit more details. I'm not going to go over there. But so while working on this My Treatment CDS hook, I discovered a lot of barriers, potentially significant barriers in implementation. So I started looking for another point of entry to kind of a with a lower barrier, and looking at the number 5. So I don't have time to review this kind of application, but technologically it's similar to having a card, like a smart health card, which would benefit with the disability case. And by giving the patient a card with the result of a certain psychological testing, sort of like that step would help tremendously to access accommodation for their schooling, for example, like transitioning to college. And there's a this is very close to my heart, this case. I'm not going to go over, but that's kind of would be very appropriate case to use the smart card, like disability-oriented. So how did I navigate this unfamiliar field of expertise? Number 1, ask for help. And I will mention those great community supports and resources in my acknowledgments. Number 2, I got nerdy. I set up my study plan of 20 hours a week to close my own informational gaps and kept good notes. And so, this is a GitHub page that I set up for my project. And this is a snippet of the bundle on patient data and FHIR, map the electronic health record data to FHIR, and FHIR certified. Thank you to FHIR Lee and HL7 for all those great courses. And so just, this is a deployed a Docker container for Happy FHIR server using AWS EC2, which is now managed by the ECS, a sort of type of service that is a container orchestration engine to manage all those functions. And I'm at the point of domain transfer, which I was hoping to do before the presentation today, from GoDaddy to AWS Route 253, which will then 2 more steps, Fargate computing platform, adding, and then adding this, getting security certificate. And you will say, why do you need your own FHIR server? Well, for educational purposes, and I can bring it to the Connectathon and can share with our community. And through this challenge, I felt like really defying the gravity. Like while being like, unlike this goats on the cliff, it seems to be very comfortable while navigating this vertical rock. I think it's 100 feet above the ground. I felt kind of dizzy, but lessons were my reward, and I want to recap. This project was focus on drivers of innovation and assessing the feasibility of adopting CDS technology in technologically naive environment by promoting technological literacy and community engagement. So central to my project was the idea that really resonates with me, that when healthcare providers can get engaged, and it can be achieved through making the technology understandable. And I hope to contribute to this process by sharing my experiences through writing modules, or turning my notes into modules, and providing guidance to non-technologically community with must-know lessons or details on demand and things like that. So additional driver that I think everybody will agree works in real world, and it's very easy to understand, funding initiatives. And luckily for us, and I'm happy to share that just before coming here, I have a talk with my chief who expressed interest in pursuing one of the opportunities that I kind of presented that are very much aligned with our clinic. And my boss immediately called our vendors for the urgent clinic. And prior to that, I only had 2 meetings with our vendors. And the first was a 5-minute meeting when I was introducing my project, and the second one scheduled for May 28th. It was too late to really do anything because I had to show something here. And of course, it would be really beneficial to explore additional drivers and of innovative technology and adoption, and extend the range of CDS hooks in a meaningful way. For example, it would be fantastic to display at the point of care. I dream of this score, this quality adjusted life year score, to make it easy to compare the incremental cost of the program somebody is using compared to the counterpart that is aligned with our health improvement, and express it in dollars. And I guess lastly, I just want to bring this ancient wisdom by Goethe that knowing is not enough. We must apply. And willing is not enough. We must do. And this is my acknowledgments. And some of the questions I really should post in the app, and I will wrap. And I have a lot of references, but just kind of a placeholder, and that's the wrap. I don't know how I did with time, but if you have any questions.
I think you did perfectly on time. We still have just a bit less than 5 minutes for questions. If there's any questions already? Otherwise, like the schema you showed, is that like the design for the CDS hooks, or is it already built and up and running? Or
it is designed. I have tried to different sandboxes, but I really didn't get to the point, unfortunately, that I could test any of the things. So far, I've submitted, especially the first time, I submitted to Britain to take a look. I didn't really get a feedback, so it might be throwaway diagram. I really can't really defend it.
Yeah.
So, yeah.
Awesome, thanks.
Hi, my name is Dave. Also in Optum, working on CDS hooks and that. Can you maybe just kind of recap again sort of the clinical premise that you were looking at in terms of the notification, and where in the provider's workflow that could come in? And I have to confess, I got a little lost on whether to what extent was the patient or were they just filling out the questionnaire, and how that hook comes in. So if you could just kind of recap that piece.
Thank you. I kind of didn't know if. So let me just bring you through this. They call a mental map, maybe a slide that I kind of skipped, but I think it's best to start here. So so this treatment cycle, the 1 to 4 is really in treatment, and 4 to 1 is like a discharge and care coordination. So we're focusing on actual treatment. And we, as I said, we have a lot of treatment resident patients. And so one of their most recent patients, chief complaint was, my adults are incompetent, and I really couldn't disagree. So that sort of, we don't really connect. And I work with adolescents. So let's say that in this program, and that it's just the modules. Where's this slide? Wait. Okay, so see this mental health map? So mental health map is that kind of a organizing tool for every patient to come in and say, okay, you're here at minimum 5 days, and my synthetic patient's been dragging for a few weeks, just kind of for me to understand what data we need, and so what events because I was implementing the HR, and I was kind of creating some of the things, and I saw what I did wrong. But mental health map has those sections, and I don't know how much you can see, but it's the tool is based on different evidence-based kind of recommendations to organize emotions, and that's psychiatry, emotions, volition, cognition, like how we think, how we feel, and what we do. And that kind of when this is sort of an abstract world. So clients go through the different lessons, 5 lessons each day, like dialectic behavioral therapy, cognitive behavioral therapy. And then they come up with strategies, like go through that tool, strategies that pull, extract from each module and say, this is what I can do. This is what within reach. If you heard like Vygotsky, optimal, proximal zone of proximal learning. So we can only learn what we can reach. And I spent like most of my career with autistic children, development delays. Like I came from Pediatric, so I kind of really understand the learning. So this is kind of where I embed that. So they're not, we give them lots of tools, but there could be just one thing that works, like count to 10 and nothing else really they can't apply. Then, so in psychiatry, especially in certain areas like they're like social phobia, right? You can't really get better by talking about how, how you feel when you're exposed to some socially stressful event. You have to practice. Because the nervous system really needs that behavioral desensitization and response prevention. So that's why I said that we have to, like, it doesn't really matter what the patients say, oh, I'm doing great, and they're in the milieu, they kind of role play, and they say, oh, I'm really understand everything, and then they go home, and we had this patient who needed to just kind of negotiate their sort of assertiveness, and then at time, so couldn't really handle it. So let's just pretend this. And then, so I need to wrap up, and that is the point. So they're, on day 5, they're asked to go and just to see how they do in real life. And that's where the hook, at the time of this test, they fill out this questionnaire. And then, does that make sense? I'm sorry, I kind of gave you maybe more detail.
I think otherwise we can follow up maybe afterwards.
Yeah, okay,
Thank you very much. This was great and really impressive for a physician to dive into this.
Okay.
So, thank you.
Thank you.